We'll now call for further amendments that we can. Ms. Sutton.
Thank you, Mr. Chairman. I have an amendment at the desk. It's Sutton 17_001.
Clerk will report the amendment.
Amendment to the amendment in the nature of a substitute to H.R. 3200, offered by Ms. Sutton of Ohio. And
Mr. Chairman,
Christensen
I
of
request
Virginia.
unanimous consent to waive the reading of the amendment.
Without objection, that will be the order. Gentleman from Louisiana reserves a point of order, and the gentlelady from Ohio is recognized for 5 minutes.
Mr. Chairman, can we have a copy of the amendment?
Yes. We'll hold off until member receives his copy.
Sorry.
Chair recognizes the gentlelady from Ohio.
Thank you, Mr. Chairman, and I'm honored to offer this amendment with the distinguished gentlelady from the Virgin Islands, Representative Christensen, who I will yield to in a moment. This amendment would authorize the Secretary of HHS to award grants to states, public health departments, free clinics, federally qualified health centers, and other nonprofits to promote positive health behaviors in medically underserved areas through the use of community health workers. Community health workers operate in association with local healthcare systems in both urban and rural environments and represent the first line of primary care in many parts of this country. They're utilized, as I said, by hospitals and public health departments and health centers, among others, and they operate in association with them. Various studies have demonstrated that community health workers can improve health outcomes while lowering costs, and many states have heeded that evidence, including the state of Ohio. However, existing community health worker programs struggle to find funding to cover basic operational costs, salaries, training, and many community-based organizations that would like to hire community health workers simply don't have the resources. So as I said, this would authorize the Secretary of HHS to award grants to states and public health departments and the like to help community health workers connect at-risk and potentially high-cost populations with existing services. The result will be improved chronic disease management, reduced use of emergency rooms, and fewer low-weight babies. Community health workers will play an integral part in a reformed healthcare delivery system that expands access and reduce costs. And if we're serious about expanding access and improving cost efficiency in the system, we should work with community-based organizations with existing or budding community health worker programs and help them have access to some of these resources. And with that, Mr. Chairman, I'd like to yield to my colleague, Representative Christensen, who is the co-sponsor of this amendment.
Thank you, Congresswoman Sutton, and thank you for your efforts and your leadership with this amendment to include the grant programs for community health workers in this bill. This provision is strongly supported by the Tri-Caucus. As a matter of fact, we've included it in our disparity elimination legislation in the last 3 Congresses and this one. And of course, as a physician who's practiced for more than 2 decades before coming to Congress, I do know firsthand about the incredibly instrumental role that community health workers can play, Not only are they on the front lines, especially in primary care, for so many men, women, and children in rural and low-income communities that suffer from provider shortages and inadequate health care, but many states have really shown that the community health workers actually improve health outcomes as they reduce costs. And therefore, this amendment offers a rare win-win, because it will create a way for community health workers to have the resources they need to promote healthy health behaviors and improve the health and wellness of Americans who live in areas that we know are not now well served by the current healthcare system. And they'll be doing this, providing counseling and guidance on health behaviors, advocating for individual community health needs, providing direct primary and preventive care. And as they do that, they'll be saving health dollars. And we're talking about individuals who are from the community, who share the same experiences, who have the needed level of empathy and appreciation, and who then have the trust of the members of their community as they provide these services. So I strongly support this amendment. I urge my colleagues on both sides of the aisle to support it, and to support the common sense measure of investing in those health programs that we know work, that we know will not only save money but also save lives. And I really feel strongly that this needs to be a key part of healthcare reform if all underserved communities, from the largest urban area to the most remote rural community, are to benefit from this historic legislation. And I yield back the balance of my time.
And I yield back, Mr. Chairman.
Gentlelady yields back the balance of her time. Further discussion?
Mr. Chairman.
Mr. Blunt.
Mr. Chairman, a question for council. I noticed both of my colleagues used the term community health workers. On page 5, paragraph D, it outlines that priority should be given to applicants who meet certain conditions, and then on page 6, line 2 through 3, it says that those applicants should have experience in community organizing. What does community organizing mean, and how is that different than community health workers?
I'm sorry, Mr. Blunt, I'm not able to. Could you give me those lines?
On page 6, line 2 and 3.
My page 6.
Oh, that was the original amendment language. I'm sorry. It's on page 5, looks like number 3 on page 5. Have documented community activity and experience with community health workers.
Mr. Blunt, as far as I know, the term community health workers is not defined at the federal level. I know that some states do indeed have community health workers and may define them under state law.
But number 3, you wouldn't have to be a community health worker. You would have just had to have experience with them. Is that right?
Yes, sir.
So like ACORN, could that be a community organizing, community worker group?
I have to profess ignorance. It's community health worker is, to the best of my knowledge, not a defined term at this federal level. And
But we're not talking about, we're talking about somebody who has experience with community health workers and has been involved in community activity. I suppose.
Would the gentleman yield?
I would.
Should I try?
I would yield, my friend.
Well, I think the intention here is that these grants will go to organizations or community health centers, but it can go to a not-for-profit organization, and we want to make sure that that organization has experience in training and utilizing community health workers if they're going to get these grant dollars, and that we want to also make sure that they are of the community, because we feel that those are the people who will engender the trust of the community and be able to be most effective in those communities.
So
Blunt,
if
Mr.
the
Blunt,
lady would, yeah, yes.
If I could correct myself, I'm sorry. I've been advised by Legislative
It is
Council
right
that if I'd only turn to page 8, that there is indeed a definition of community health worker here.
All right, so we'll know on page 8 who these people could have talked to, but we don't know who they would be.
So
Page 8 apparently says who the community health workers are, but it doesn't really say what it means to have had experience. But I take my friend's statement there that these would be people who were of the community and had experience with community health workers. That seems pretty undefined to me. This is $150 million, I guess $30 million a year for 5 years. If I calculate right, that's just the daily interest on the approximately $1.2 trillion this bill cost. So $150 million, I think, is one day's interest on $1.2 trillion. All right, that's, who wants time? Chair, I'll go to the chair.
Just briefly, I think what Congressman Blunt just pointed out, and the council was wise enough or honest enough to admit, there's not a real definition about the question of this nonprofit groups who have documented community activity experience with community health workers. Would the authors of the amendment be willing to withdraw it and let us work out some language on exactly what that is?
Mr. Chairman.
I yield the gentlelady from Ohio.
Thank you. Well, I think counsel misspoke when he first answered the question. Page 8 does define community health worker, and perhaps you all will find some assurance on page 6 when we talk about there are a lot of safeguards built into this this amendment. The Secretary is required to establish guidelines for assuring the quality of the training and supervision of community health workers under the program, and for assuring the cost effectiveness of such programs. There's also a requirement for the Secretary to monitor the program, as well as, of course, there's a report that will be done and reported back to Congress to see that, that this program works as required. And so I think that I feel comfortable with the legislation as it is, and I would hope that maybe with looking at those provisions, it would give you a level of assurance to proceed.
Well, our time has expired, but hopefully sometime in this debate we can get, I want to comment about this definition a little bit more, but the time's expired.
Time has expired. Further discussion of the amendment. Ms. Schakowsky.
Yes. I wanted to give an example. In the last couple of weeks, I met with Mount Sinai Hospital in Chicago, which is a hospital that serves a very low-income community. And they developed a program where they have community health workers that are going out and meeting with, going to people's homes that have asthma and teaching them how to manage their care, how to correctly use the inhalators, and about dust and about all kinds of things that are in the home. They told me that because of that program, they have reduced emergency room visits for asthma by 65%. And they gave me a dollar figure, which I can't remember, but a significant dollar figure, far beyond the cost of hiring these community health workers. And they were talking about the various other programs that they were going to initiate in order to reduce the cost for them of health care through the use of these community health workers. And the other point that they made is that, of course, by definition, these are people from the community who are now getting jobs. And, you know, they're not paying them a heck of a lot of money, but it's a really important way of employing people in the community and having incredibly successful health outcomes. So I really wanted to support this amendment. I'll yield to Mr. Sarbanes.
I just wanted to follow up. I appreciate Ms. Schakowsky yielding, but today, by coincidence, at 11:30, I visited a program in Baltimore called Baltimore City Healthy Start, which is a program that works with expectant mothers throughout the city. There were 9,000, I think, births in Baltimore City last year. This organization, which is a 501c3 nonprofit, served 1,000 of those women, and it did it primarily through the use of community health workers, which are defined for their purposes as people who came out of the community. And they testified to me that that made a big difference, because these are people who reside in the community, they have relationships in the community, they have the credibility that comes from being from that community. And it enhances their ability to reach out and provide these services. They're exactly the kind of group that would be a potential candidate to receive funding under this grant program. So I strongly, strongly support this amendment. I thank Ms. Sutton and Ms. Christensen for introducing it. And I yield back to Ms. Schakowsky if she so wants.
I yield back the balance of my time.
Gentlelady yields back her time. Mr. Scalise. Oh,
I'm sorry.
Thank you, Mr. Chairman. In addition to the language on page 5, which gives priority not to community health workers, but to applicants who have documented community activity and experience with community health workers. And I think when you go to page 1, it allows them to provide outreach in a community setting. And what's I think more concerning is on page 2, to provide experimental learning opportunities that target behavioral risk factors, including risky sexual behavior. Now, I'd ask counsel if you can explain to me what is or isn't
Will the gentleman yield?
to provide experimental learning opportunities to children with risky sexual behavior.
Will the gentleman yield?
I'd yield.
The word is, it's not experimental, it's experiential.
Experiential. Well, you can explain that to me then. I'll be happy to have you describe the difference there. If they're experiencing risky sexual behavior, what are you going to allow these community activists to educate them about?
Would you like to, counsel like to answer, or would you like me to answer?
I'm yielding back.
Thank you. I'll be happy.
I'll let you answer that one.
I'll be happy to answer. Look, when you look at page 2 and you look at the behaviors elicited there, obviously these are all things that we know that if people were educated about in a more comprehensive or a more effective way, we can reduce the bad health outcomes, and obviously we're trying to increase in the long-term cost efficiency.
In regaining my time, if you're talking about licensed professionals in a setting where maybe a parent had the ability to approve somebody talking to their child about risky sexual behavior, that might be one thing, but this is allowing organizations with community activity experience, groups like ACORN, who have very questionable legal backgrounds that are well documented, would have access using these federal funds to provide this experiential learning opportunity to a child, talking to them about risky sexual behavior, and nothing in here from what I can see even allows or requires parental consent. And so I would ask counsel, would it allow some community activist to talk to a child about risky sexual behavior without their parents' consent? Or if you can show me where it's prohibited, because I surely don't see anything that would require parental consent for one of these community activists.
Mr. Scalise,
to provide this outreach, quote unquote, on experiential learning opportunities.
I would just...
I'm asking counsel.
Oh, I'm sorry.
Mr. Scalise, there's nothing in this language that would prohibit or require parental consent.
So it would be allowed without parental consent. I know the ranking member had a question he wanted to ask. I would yield to the ranking member.
If I may, Mr.
Yeah.
May I continue?
Yes.
And as such, without addressing this directly, I would assume, looking at other laws of this sort, that applicable state laws would continue to apply, and that state laws governing parental notice and consent.
So if a state does not have a requirement of parental consent, then
the state law
it would be
is
allowed.
silent on the point, then the federal law would not be, there would be no state government.
And then they could do it without parental consent unless the state had specifically prohibited, which many states haven't prohibited specifically.
I mean to say I see nothing in this provision that would preempt an applicable state law.
Okay. And the ranking member, I know, had a question. I would yield to him.
I just want to comment on the eligibility on page 9, line 16. You know, I am not comforted by the gentlelady from Ohio's explanation that eligible entities are covered, because the definition of an eligible entity means any public or nonprofit private entity. Now, you've got some examples, but as it's currently written, this language, any public or nonprofit private entity in America qualifies. Acorns would qualify. So at the appropriate time, I'm going to ask unanimous consent to amend the eligibility with the phrase whose primary purpose is health education or treatment. so that we at least limit these grants to public and nonprofit private entities whose primary purpose is providing either health services or health education. So with that, I mean, that's just, the definition of an eligible entity is any public or nonprofit private entity in America, and that's it's a pretty broad net. I yield back to Mr. Scalise.
Mr. Scalise's time has expired.
Yield back, Mr. Chairman.
Ms. Christensen?
Thank you, Mr. Chairman. I'd just like to try to respond to the ranking member. I think to define it by those who normally provide services in healthcare may be too limiting. We'd be limiting a lot of not-for-profits that are associated with churches who have been getting very involved in health outreach, and many, many worthy organizations that just have the trust of the community, and with the training in healthcare, they'll be able to provide those services. I think to just limit it to those who are now providing healthcare.
Well, would the gentlelady yield? If y'all withdraw this and we can have a discussion over the next several hours or maybe we can come up with a definition. I have no problem if you want to put faith-based organizations. I can live with that. But your current eligibility, I would hope even the authors would admit, is extremely broad.
And just reclaiming my time for a minute, and where we have the priority in awarding grants and we talk about have documented community activity and experience with community health workers, I think that's the more specific criteria, that they have experience with community health workers and have documented community activity, meaning activity within that community. We're not talking about, we are specifically not talking about people coming from an outside a community to go into a community to do this. We're talking about community organizations that are in that community, that have the trust of that community and have had experience with training.
But that's not what your eligible entity definition says. It doesn't say that.
Will the gentlelady yield?
I'll yield to
The gentlelady from Virgin Islands
co-sponsor.
has the time.
I'll yield to my co-sponsor.
I thank the gentlelady. And again, I think that you're looking at one provision in the bill, but there are a lot of provisions here that are going to hopefully provide you with some assurance. When you look at the fact that it's an eligible entity to apply, there's a lot of oversight. I mean, when each eligible entity that desires to receive a grant shall submit an application and accompanied by such information as the secretary may require. This just doesn't happen willy-nilly here. It's going to have to describe the activities for which assistance is sought under the section, contain an assurance that with respect to each community health worker program receiving funds under the grant, such program will provide training and supervision to community health workers to enable such workers to provide the authorized program services, which are, of course, solicited in one of the provisions that we spoke about earlier. So, and as I said, there's also provisions to require, and the application is going to require an assurance that the applicant will evaluate the effectiveness of the community health worker programs receiving the funds. There's a lot of other provisions within this amendment that I appreciate your concerns, and hopefully these provisions address those concerns.
Will the gentlelady yield?
It's not my time. I yield back to the gentlelady from
Will the gentlelady yield to
Virgin
me?
Islands.
It seems to me that if you look at this secretary, in collaboration with the director of the Centers for Disease Control and other federal officials determined appropriate by the secretary, is authorized to award these grants to eligible entities for the purpose of promoting health behaviors. And then on page 3, there has to be an application to the secretary, and that application has to show they'll provide training and supervision to community health workers to enable them to provide authorized services, contain assurances the applicants will evaluate the effectiveness of their programs, contain an assurance that each community health worker program getting funds will provide services in the cultural context most appropriate. Then you have the oversight provisions. What was pointed out was page 9 describing eligible entity, which means a public or nonprofit private entity or consortium. Well, what was pointed out is that could mean anything, but it couldn't just mean any group. They're eligible, but then they have to meet the criteria set out by the Secretary with the Centers for Disease Control to determine that they've got an application that they're going to do the job that needs to be done. And there are oversight provisions in this. It seems to me that there's a straining to try to find something wrong with what looks to me like a very good proposal. I don't know if ACORN would qualify or not, but just because they're a community organization doesn't mean they're going to get a grant. It has to be a community organization or people working with community organizations that can do the job. So I thank you for yielding to me, and I support the amendment.
Parliamentary inquiry.
Who seeks a parliamentary inquiry? Yes, gentleman from Arizona.
Can you tell me how many days of hearings we've held on this proposal? I withdraw the inquiry.
Gentlelady from Tennessee.
Thank you, Mr. Chairman, and I appreciate the recognition. And I do have a couple of questions for the author of the amendment. I think they can answer those, or Ledge Council can, and I appreciate their patience with answering the questions. Some of us who served in state legislative bodies as welfare reform was implemented know that as we sought to educate and train and involve people in the process, when there was the pool of money to help pay for this, we had some organizations that were not as well trained and not as well qualified who showed up wanting to participate in that process. Now, I've done lots of work with Children's Hospital and the Lung Association and the Arthritis Foundation and the Cancer Society and the Heart Association and organizations that have used volunteers to help educate and train people how to interface and how to take advantage of health care that was there for them, where to find that health care. But it is of tremendous concern to me that the way this is written with any public or not-for-profit entity that has experience in community workers and community health workers can come in and apply. And it concerns me also on page 6, where you have your evidence-based interventions. And it says the Secretary shall encourage community health worker programs receiving funding under this section to implement an outcome-based payment system that rewards community health workers for connecting underserved populations with the most appropriate services at the most appropriate time. Now, we all like to see good work incentivized. I don't think anyone has a problem with that. But what about smoking cessation programs that maybe are not credible? What about alcohol and drug treatment programs that don't have the type outcome we would like, but yet maybe it's a not-for-profit that administers that? What about abortion services? What about the fact that they would be incentivizing any of these activities on page 2 that are listed, activity A through J? If you have a state that is not a parental consent state, what do you lay yourselves open to, and who would be expected to assume the liability? And I will yield to the bill's sponsor for a response.
First, let's clarify from council about some of the things that you ticked off there about being a part of the amendment. Certainly abortion services are not listed as one of the provisions of the bill.
If the gentlelady will yield, I'll reclaim my time.
It's your time.
And ask council, would Planned Parenthood qualify for being a not-for-profit that could access these funds?
I don't know the answer.
I yield to the council.
If I'm making the assumption without knowing it that Planned Parenthood is indeed a private nonprofit entity.
Reclaiming my time. So they could be considered. And so the burden would then be on finding a way to exclude them from this. And I yield to the council. I can see he wants to make another comment.
Ms. Blackburn, the only activities for which funds are provided in this section are to educate and make referrals. There is no provision in this section for actual providing of service.
Reclaiming my time, and I realize that. And I also realize that sometimes it is that making the referral and being paid a bonus, if you will. If you look at page 6 to council, and they are going to be paid a, they will implement an outcome-based payment system that rewards community health workers for connecting underserved populations with the most appropriate services at the most appropriate time. So it would concern me that this is not defined in the language as what is specifically excluded and what groups are specifically allowed and are not allowed, and then that there would be that incentive program that was there. And my time has expired, and I yield back my time.
Gentlelady's time has expired. Mr. Wiener.
Let me just, first of all, if it's not clear enough to my colleagues that we want to assure quality, read the quality assurance section. If it's not sure that there's going to be monitoring, read the monitoring section. If it's not sure what criteria you'd have to face, read page 3 through 5. But let's not lose sight of the forest for the trees. If you're going to get control of health care costs, we can't simply provide health care to some communities in emergency rooms. We can't wait from someone who has stage 1 breast cancer to get to stage 5. It's too expensive. It's inhumane. It doesn't make any sense. I believe in everything I've heard from my Republican friends. They recognize that in their proposals, that we need to make sure we have different ways of providing health care, that we try to encourage people to get preventative care, for example. We try to encourage people to live more healthy lives. That makes quality health care decisions, and it also saves money. What the gentlelady is proposing is to put some people at a relatively inexpensive cost, hyper supervised by the Department of Health and Human Services, to try to provide those services, to try to help steer people towards smarter decisions. If you're not, I mean, I have seen nonstop defense of the status quo, even the parts of the status quo you yourself say need to be changed. You know, you're so hidebound to protecting our health care exactly the way it is that even the most obvious flaws you're raising red flags about. Don't worry. ACORN isn't going to go register Democrats and give smoking exams. Don't worry about it. What we're trying to do here is fundamentally change the things that we're doing wrong in health care. You're so staring at the trees, you're losing sight of the forest. Too many people in this country are getting end-of-life care at the early stages of their life because we're not giving them smart health care options. Too many people have no other choice except to go into their neighborhood emergency room to get care. It's not, you may not care about them. Don't. Care about us. It's our tax dollars that's paying. It's our insurance that's going up too high. It's our doctors that are stuck taking care of them rather than doing things that are smarter from a monetary perspective. I mean, I understand you want to parse the sentence in the line, and I understand part of the strategy is drag it out as much as possible, raise whatever red flags you can. I mean, I am surprised ACORN came up in this debate, but it's obviously one of the talking points. But let's remember a little bit about what we're all trying to accomplish here. And I'm pretty sure it's in your plan, too. It's take healthcare decisions that are costing a lot of money and try to cut them off early by making ones that can save us a lot of money and also save people's lives. This list of things that's on page 2, do you think it's a bad idea to steer people away from bad nutrition? Is it a bad idea to steer them away from physical inactivity? Is it a bad idea to steer them away from being overweight and to using tobacco? Of course you don't. I know you don't. Even in the midst of all the political back and forth, you don't believe that. And so what Ms. Sutton is trying to do and what Ms. Christensen is trying to do is say, you know what, let's put some people in these communities supervised, chosen by the department after a long list of qualifications they need to meet, and try to achieve those things. I mean, I understand you're in love with the status quo, but I got news for you folks. You're all alone. Nobody else thinks the status quo is the best way to provide health care, and Ms. Sutton is recognizing that that's the case. So if you have a technical thing with the bill, that's one thing. But I would encourage you all to begin your remarks by saying, Ms. Sutton, great idea. We do need to do these things. Ms. Sutton, you're doing a great thing. We do need to change the way we provide health care in this country. If we get stuck in the same exact paradigm year in and year out, and we're looking for goblins in these bills in the form of Acorn or whomever else, we're never going to solve these problems. We're having a markup here, so if no one else says it, Ms. Sutton, Ms. Christensen, this is a good idea. That's why we're going to pass it, and we're ultimately going to improve health care.
Will the gentleman yield?
Sir, I'll yield to whomever.
Right here.
Sure, just line up.
Mrs. Sutton,
yes, sir.
Ms. Sutton, that's a great idea. The national, excuse me, the deficit this year is over $1 trillion. Thank you.
That's right, and I'm just reclaiming my time. If you want to start to get health care inflation under control,
gentleman yield?
Here, let me just respond to the gentleman's point. I'm not 100% sure what it was,
point?
but let me try to respond to it. If we want to try to get health care expenditures under control, we have to not be spending all of this money after people have started smoking, after they become obese, after they've made the wrong health care decisions. We have to try as best we can to use our doctors, use our health professionals, and use our community organizers to try to steer towards less expensive.
Will the gentleman yield?
Certainly I will.
Yeah, the problem is this proposal, as it's scored, shows massive increases in government spending that's sure to increase the deficit, not reduce it.
Wait, request unanimous consent for 30 additional seconds just to respond.
Yeah.
Without
I have to
objection.
tell you something. This is a fundamental conversation. We're going to have it throughout the night, I think. We are going to be spending some more money now on some things, but we are in the aggregate going to be saving a lot of money. Because
But
the amount of
if the
money...
gentleman will yield,
Well, just
show me how Medicare and Medicaid is done.
I'm going to tell you how. I'm going to tell you how.
If the gentleman would yield, do you
Time
have
out,
an
time out,
example?
Time out. Let me finish my response. Let me finish.
Gentleman from New York has the
Let
time.
me explain how this is going to work. Right
Just
now,
expired.
Which has expired. Yeah.
Gentleman from New York, without objection,
Let me
recognized for
just
another
say,
10
you know,
seconds.
I'll give you an example. In your state of California, in my state of New York, we spend billions of dollars on the uninsured, billions of dollars of people who are getting the most expensive type of health care. So yes, we may provide $1 more of health care and $1 more of community outreach to prevent $5 in lower taxes in California, and Lord knows they need them.
But no economist is with you on
that's
these spending
ridiculous.
projections.
That's ridiculous.
No economist is with you.
Everyone I know, including, you know, I saw Mr. Steele as the
Gentleman's
Republican
time.
Party give a speech
Go
today.
ahead.
where he encouraged
Chairman.
things.
Gentleman's time has expired. Oh, I'm glad he spoke, because we got a lot more people now
Well,
ready to
Anthony
speak on
has
this
a
amendment.
way of doing that.
Chair recognizes Mr. Barton.
Mr. Chairman,
And he can-
Texas.
Mr. Chairman, could I get a second reading of his speech? I was asleep the first 30 minutes.
Mr. Barton.
Yeah. Well, some of what my distinguished friend from New York City said, I agree with. I think Congresswoman Sutton and Congresswoman Christensen, or Dr. Christensen, have a good idea, but it needs some work. You'll notice in the Republican suggestions or debate on this amendment, we're not saying it's a bad idea. We're saying let's try to perfect it. Now, I do, and I think it's a legitimate concern about the eligibility. As it's currently drafted, it's any public or nonprofit private entity. Now, let me give you a good example. My wife works for John Peter Smith Hospital, which is a public Tarrant County owned and operated hospital. They have community health centers. They have health-based clinics in schools, in kindergartens. They have outreach community centers all throughout Tarrant County. They provide services even extraterritorially outside in some of the rural counties that don't have a public hospital. They would obviously, they're a public nonprofit, they would qualify. And hopefully they would apply for a grant and they would get the grant. But let me give you some other examples in my district that under this definition would also qualify. And they're not acorns. I'm not talking, the Little League would qualify. The Girl Scouts and Boy Scouts would qualify. There is a group that puts on a 4th of July parade that is a public nonprofit. They work with the community health groups, providing health outreach for for the people that watch the parade, they would technically qualify. Now, all we're saying is if you're going to move forward with a good idea, prevention, wellness, underserved communities, all the things that they talk about in the first part of the bill, help us define the eligibility to those groups that have some proven record of interacting with underserved communities in a health-related or some sort of a field that you want to. We're just saying this is too open-ended. That's all. And if you don't want to withdraw the amendment and work with us for the next night or the next day, just because the Republicans are sitting here saying let's think about it, doesn't mean that we don't support it. But what my friend from California, Mr. Radonovich, said earlier, we do have a huge deficit, and you're providing grants, and when you're going to provide a grant, you're going to provide money. If you have a wide open eligibility of those groups that can apply for it, and you don't constrict it, you don't try to define it in a little bit more precise way, pretty good chance some or a lot of that money is not going to be very well spent. That's all we're saying, and I'll be happy to yield to Dr. Murphy.
Thank you, Mr. Barton. I guess I want to speak more as a psychologist here than as a member of Congress. And as the days heat up here, and as the night goes on, I get concerned that we're confusing intent with content. And we have occupied a lot of time in the last couple hours arguing about intent. So I would suggest that we get back on track and don't argue about what's in persons' minds or hearts, their intentions. Because good ideas don't necessarily make good law, and sometimes good laws are hard to swallow. I also think there's a lot that is in this, and I certainly support a lot that is in this amendment. But given that this is the biggest health care bill this nation has dealt with in the last half century, and its implications are going to carry us another half century, I hope that we can stick to the issues at hand. And with that, I yield back to the chairman.
What did you back to me? Okay, I once again want to ask the authors of the amendment if they're willing to either withdraw it so we can tighten up the eligibility requirement, or work with our staffs very quickly to see if we can come up with something that we can put in the amendment.
Will the gentleman yield to me?
Be happy to.
Why not adopt this amendment, and if you have further changes, you can talk to the authors, and we'll have those as an amendment later on.
Because we don't have an assurance that there will be a productive exchange if we accept it as is.
Joe, would you yield for one minute? Or a few seconds? Because if I'm in a position where I'm going to be voting to give Planned Parenthood money, even though that may not be, Anthony, the intent, but clearly they will, or ACORN or others that we don't think, and we have an opportunity to sit down, Mr. Chairman, and maybe agree on public hospitals and recognized health centers as the conduits, then I think we could come to an agreement. But right now, I'm not in a position where I could vote for it.
And time has expired.
Mr. Chairman.
Who seeks recognition? Anybody on the Democratic side? Who on the Republican side? Mr. Deal.
Thank you, Mr. Chairman. I'd like to engage counsel in a colloquy. If you would look at page 2 of the amendment beginning on line 20, it provides that one of the purposes for which these grants could be given is to educate and provide outreach regarding enrollment in health insurance, including the state children's health insurance program. Can counsel tell me if we did not have funding in the SCHIP reauthorization that this committee and Congress passed to do exactly that in the SCHIP bill? And if so, to what extent do we fund that?
It is my memory that there is outreach and enrollment activity funded in the SCHIP legislation. I do not have it in memory how much money, or if it's indeed set aside as a discrete amount.
And then the next part is to do the same thing with enrolling in Medicare. Is there not funding already in the current Medicare law?
Yes, sir.
To do that? And also in the content of this bill on page 414, where it's talking about linguistic issues and giving priority to community organizations for enrollment in Medicare on page 414 of the underlying bill, there's authorization for grants in the underlying bill for Medicare enrollment, is there not?
Yes, sir.
So we've got it in the existing Medicare law, we've got it in another portion of this bill, and now this amendment seeks to add a third time to fund the very same thing. And the third category is Medicaid for enrollment there. When we expanded Medicaid eligibility, we also included, and there's significant money in Medicaid for states to have outreach. In fact, we reward states for their outreach and give them extra funding if they will increase their enrollment in eligible Medicaid populations, do we not?
There is significant funding available for outreach and enrollment under the Medicaid program under the category of administrative costs.
And this one proposes to do it again?
Yes, sir.
Thank you. I yield back.
Further discussion?
Mr. Chairman, I wonder, do we have a representative from the Congressional Budget Office in the room with us tonight? I just think it would be very helpful to get their opinion as to, we've heard a lot of testimony both sides, and some of these programs seem worthwhile, some of them do seem vague and duplicative, and we do have a problem with the amount of money we're spending in this Congress. We have a problem with the amount of money we're spending in this bill. I have previously tried to get H.R. 914 through. I'm blocked at the Congressional Budget Office because it costs $200 million over 10 years to train new primary care doctors, and yet we're hardly flinching at spending $150 million over 5 years to train community health workers. I don't know that we're really going after value here with what we're spending in this bill, and I just think it would be helpful to have someone from Congressional Budget Office help us with those decisions, and I would support Ranking Member Barton's request that we pull this offline for a short period of time and see if we can't work through some of these problems. And I'll yield back.
Gentleman yields back. Further discussion on the amendment?
Mr. Chairman.
Who's asking for recognition?
Right here.
Gentleman from Oregon.
Well, Mr. Chairman, if this is brought up to a vote right now, I suppose I'll reluctantly oppose it. Representing a district that's 70,000 square miles, you want to talk about underserved populations. I've got counties with no hospitals, no doctors, who have to cobble together every penny they can just to keep their clinics open. And then I hear from my other providers the desperate need for general practitioners, as referenced by Dr. Burgess. It seems to me if we've got an extra $150 million, putting it into actual delivery of service to people in need would be the best expenditure through the health clinics, through educating more general practitioners. Home health care. I've got home health care agencies that are having to pull back. In the Medicare Part D legislation, we had a 5% add-on for rural areas for home health care that expired. We've not been able to get that renewed. I mean, there are a lot of promises and pledges out there already that are unfunded, and yet here we're going to apparently create another program that is not duplicative but triplicative of existing law in some cases. And so I'd just soon have us bring it back as well and get this worked out.
Gentleman, yield to me?
I'd be happy to yield.
Sounds to me your argument is a bit different than those who are arguing we ought to clarify exactly who may seek a grant.
Well, I actually share that argument too, but I thought it had been well made. I didn't want to be quadruplicative.
But your argument that you just made focused more on the fact that this may not be the best use of funds.
I share both.
Given other needs. So I could understand both arguments. So withdrawing it for a short period of time may lead to pinning down and narrowing exactly who the grantees may be, but withdrawing it may not satisfy those who don't want to spend the money. So I think it's legitimate for you to oppose it on that basis. I do want to point out to the members of the committee that we've already adopted, over my objection, the ability for the Secretary to just unilaterally eliminate duplicative and even triplicative programs. So perhaps that can ease your mind.
Well, reclaiming my time, if the chairman doesn't mind.
I'm starting to like that proposal better.
Well, I'm just trying to reduce the workload on the Secretary, since if we approve this amendment, we'll knowingly be creating a triplicative grant program. So we can actually prevent that waste of the Secretary's time. We can save $150 million that could go to all kinds of groups without any great expertise in actually helping sick people. Now, I believe in this outreach. I got that piece. I just know ahead of that, there's a long line of people waiting to get access to care in facilities like the Asher Clinic in Fossil and, out in Nissen around. I mean, there are lots of small communities in my district where a few tens of thousands of dollars could keep the lights on, the doors open, and care given. I think they'd rather have the money focused there than in some newly created federally funded outreach process.
Gentleman, yield back his time.
I do, sir.
Are we ready for the question? The vote now comes on the Sutton Christensen amendment.
Parliamentary inquiry, Mr. Chairman.
Yes, state your parliamentary.
Is what we're doing experiential?
I'm not qualified or eligible to answer that question. Don't give me any grants to study it. We now vote on the Sutton Christensen amendment. All those in favor of the amendment say aye. Aye. Opposed, no. The noes are dribbling in, but the ayes have it.
Mr. Chairman, I'd ask for a roll call vote.
Okay, we'll proceed to a roll call vote.
Mr. Waxman.
Aye.
Mr. Waxman votes aye. Mr. Dingle. Mr. Dingle votes aye. Mr. Markey. Mr. Boucher. Mr. Pallone. Mr. Pallone, aye. Mr. Gordon. Mr. Gordon, aye. Mr. Rush. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Stupak. Mr. Engel. Mr. Engel, aye. Mr. Green. Mr. Green, aye. Ms. DeGette. Ms. DeGette, aye. Mrs. Capps. Mrs. Capps, aye. Mr. Doyle. Mr. Doyle, aye. Ms. Harmon. Ms. Harmon, aye. Ms. Schakowsky. Ms. Schakowsky, aye. Mr. Gonzalez. Mr. Gonzalez, aye. Mr. Inslee. Mr. Inslee, aye. Ms. Baldwin. Ms. Baldwin votes aye. Mr. Ross. Mr. Weiner. Mr. Weiner, aye. Mr. Matheson. Mr. Matheson, aye. Mr. Butterfield. Mr. Butterfield, aye. Mr. Melanson. Mr. Barrett, oh, sorry. Mr. Melanson. Mr. Melanson votes aye. Mr. Barrow, sorry. Mr. Barrow votes aye. Mr. Hill. Mr. Hill votes aye. Ms. Matsui. Ms. Matsui, aye. Mrs. Christensen. Mrs. Christensen, aye. Ms. Castor. Ms. Castor votes aye. Mr. Sarbanes. Mr. Sarbanes, aye. Mr. Murphy of Connecticut. Mr. Murphy, aye. Mr. Space. Mr. Space votes aye. Mr. McNerney. Mr. McNerney votes aye. Ms. Sutton. Ms. Sutton votes aye. Mr. Braley. Mr. Braley, aye. Mr. Welch. Mr. Welch votes aye. Mr. Barton.
Yes.
Mr. Barton votes aye.
I vote no, excuse me. Momentary brain lapse there.
Mr. Barton votes no. Mr. Hall. Mr. Hall votes no. Mr. Upton. Mr. Upton, no. Mr. Stearns. Mr. Stearns, no. Mr. Deal. Mr. Deal, no. Mr. Whitfield. Mr. Woodfield, no. Mr. Shimkus? Mr. Shimkus, no. Mr. Shattuck? Mr. Shattuck, no. Mr. Blunt? Mr. Blunt votes no. Mr. Boyer? Mr. Boyer, no. Mr. Radonovich? Mr. Radonovich, no. Mr. Pitts? Mr. Pitts, no. Ms. Bono-Mack? Ms. Bono-Mack, no. Mr. Walden? Mr. Walden, no. Mr. Terry? Mr. Terry, no. Mr. Rogers? Mr. Rogers, no. Mrs. Myrick? Mrs. Myrick, no. Mr. Sullivan? Mr. Sullivan, no. Mr. Murphy of Pennsylvania? Mr. Murphy, no. Mr. Burgess? Mr. Burgess, no. Ms. Blackburn? Ms. Blackburn, no. Mr. Gingrey? Mr. Gingrey, no. Mr. Scalise? Mr. Scalise, no.
Yes, Mr. Boucher. Clerk will
Mr.
recognize
Boucher.
other members.
Mr. Boucher votes aye. Mr. Markey? Mr. Markey votes aye. Mr. Rush? Mr. Rush votes aye. Mr. Stupak? Mr. Stupak, aye. Mr. Ross? Mr. Ross votes aye.
Have all members responded to the call of the roll? If so, the clerk will count the votes. Clerk will announce the vote.
I am, sir.
On that vote, Mr. Chairman, there were 36 ayes and 23 noes.
36 ayes, 23 noes. The amendment is agreed to.